Hi everyone, this is PT862 and in this lecture we're going to be discussing patellofemoral pain. The objectives for the lecture will be to distinguish between normal and abnormal anatomical and biomechanical considerations for patellofemoral pain. Identify risk factors associated with patellofemoral pain, determine signs and symptoms associated with patellofemoral pain, and understand an evidence-based approach for the management of patellofemoral pain. We're going to start out this section by looking at some of the anatomy and the biomechanics of the patellofemoral joint and the knee itself. So it all starts with the patella when we're discussing patellofemoral pain. So the patella increases the moment arm of the quadriceps. It provides bony protection to the femoral condyles. It also prevents compressive forces on the quadricep tendon. There's a trochlear groove that the patella rests on, and it slides up and down superiorly and inferiorly as you go into flexion and extension. The quadriceps muscle obviously is attached to the patella through the quadriceps tendon, so that's the primary muscle group that's going to be associated with some of this patellofemoral pain. The IT band is lateral, and then the hamstring, specifically the biceps femoris, has been associated with some patellofemoral pain presentation. So each of these structures plays a significant role in patellofemoral pain, and our management strategies might adjust depending on which structures are involved. Now, I will say it's fairly difficult, and the majority of the time we're going to be unable to identify the specific structure involved. However, sometimes we are able to pinpoint that. To briefly review patellofemoral arthrokinematics, the patella lies within the quadriceps tendon. It increases the mechanical advantages of the mechanism, provides stability, and it minimizes forces placed on the femoral condyles. So it serves many different purposes, and a lot of it comes down to the mechanical efficiency of knee flexion and extension. The patella increases the angle of insertion for the quadriceps. It allows for increased torque producing capability of the quadriceps. There's a lot of physics that can go into it, but all you need to know is that the patella allows for increased torque capabilities for the quads. If your knee is in a rested position closer to extension, you can change the position or glide the patella in multiple different directions. So flexion and extension allows for that superior and inferior glide. If you're going through mobilizations, you can also do medial and lateral glides. You can do medial and lateral tilts, medial and lateral rotation, and then anterior and posterior tilts. Here are a few pictures just looking at the things we just discussed with the different glides and different positions of the patella itself. You can see different lateral medial glides and then the tilts associated with those. You can also see in the bottom pictures the orientation of the patella. They label it normal orientation and lateral medially rotated. Now, I think that's more of just an observation. We're not going to use that in our treatment for patients with patellofemoral pain because it's not really associated with patellofemoral pain. However, I think it's good to have a basic understanding of the human body and the anatomical position of the joints, so being able to appreciate these different positions can be helpful. During open chain movements, the patella is moving on the femur, and during closed chain movements, the femur is moving on the patella. Now, patellar movement is typically described as the patella moving on the femur, even during closed chain movements. However, it's important to make that distinction and understanding which bones are moving on which. The relative patellar position and area of contact with the femur changes with extension and flexion. The more flexion, the more distal the patella is along the femoral condyles, and vice versa. So with more extension, the more proximal the patella will be. The resting position of the patella can be described in a couple different ways. Patella alta is considered to be a high riding patella, and patella baja is considered to be a low riding patella. It has been found that if you have patella alta, it's usually due to a longer patellar tendon, and that may increase the risk of subluxations of the patella and dislocations of the patella. For patellar baja, they have theorized that it may increase the likelihood of excessive compressive forces on the patellofemoral joint due to the resting position and the mechanical advantage of the quadriceps pulling through that patella, just pushing it into different positions, leading to higher compressive forces. Now, I don't know if this has been studied very thoroughly, so it's mostly just theory at this point, based on biomechanical principles. The forces on the patella change based on two primary things. The first being the amount of force going through the quadriceps muscle, pulling on the patellofemoral joint, and the other would be the knee flexion angle. Some studies have shown that max torque occurs between 45 and 70 degrees of knee flexion. And then the other area of interest here would be the patellofemoral joint reaction force, as this kind of describes how much force is going through that joint during different movements. And there's a couple studies that have looked at this. The practical example that I think of and how it was looked at during these studies is a squat with some resistance, and trying to determine if increased resistance increases the amount of that force through the patellofemoral joint, and in addition to that, how much knee flexion during the squat creates that peak joint reaction force. The first study was published in JOSPT in 2002. However, the problem with this is it was a really small sample size, only looking at a handful of females, so it was only females as well. And they found that there was no difference in the patellofemoral joint reaction force at 70 degrees, 90 degrees, or 110 degrees. However, it was later looked at by Cotter in 2009. He actually did his dissertation on this at Ohio State, and he found that with increased knee flexion, there's greater patellofemoral joint reaction force. He looked at it a little more thoroughly, so I think based on the information that we currently have, we're pretty safe to say that during a resisted squat, increased knee flexion leads to increased patellofemoral joint reaction force. Now, whether that applies to a patient's presentation of patellofemoral joint pain or not, it probably depends on the situation. If you do have a patient who is lifting heavily at work, repetitively, getting into a deep squat over and over and over again, it could definitely be contributing. If you have a patient who goes from doing no squatting activities to doing a lot of squatting activities, it could be related to their pain presentation. However, if you have a patient who doesn't really squat a whole lot, who doesn't do any excessive amounts of resisted squatting, then it's going to be hard to say whether or not that's actually associated with their symptoms. I would argue the majority of the time when we have a patient who's presenting with patellofemoral pain, if it's not acute and not a load management problem, then we need to definitely be taking a holistic approach using the biopsychosocial model to address the many different factors that could be contributing to their pain experience. One way you can think of the patella is that it acts as a spacer. It increases the internal moment arm of the knee extensor mechanism. And there's three factors that influence the length of the internal moment arm: the shape and position of the patella, the shape of the distal femur, and the migrating medial lateral axis of rotation. Something for us to consider during our observation during the objective exam would be these anatomical considerations. The Q angle, increased Q angle suggests greater lateral forces on the patella. Static and dynamic Q angles, so we're talking about this genu varum or valgum, and then hip muscle weakness. Now, we'll talk about these in much more detail in the later slides, but you've probably seen in the clinic how these things are often looked at and prioritized in some cases for the management of the patient's pain. And even before the management, really a lot of clinicians focus on these few variables to educate their patients on why they're having this pain. And I hope that we can demonstrate that we need to go beyond that and consider much more than just these observation characteristics. We can talk about all of these biomechanics, but I think it's important that we look at the reality of the biomechanics within patellofemoral pain. So we're going to look at what the evidence says about our ability to assess knee varus and valgus, structural changes and its association with PFP, biomechanics such as dynamic valgus and its association with PFP, and we're going to look at a current pain model for PFP. The reason I want to do this is there's a huge discrepancy out there between the biomechanical narrative and the current pain narrative on why people are having PFP. So we just looked at the biomechanics, and I think it's important that we have a good understanding of the biomechanics of the knee joint, but now we're going to look at what evidence is telling us in its relationship to pain presentations. First, I want to look at our ability to visually assess knee valgus and varus. We've referenced this study before, but I want to take a more in-depth look at it here because I think it's really relevant for this patient population. And this study looked at lower limb visual inspection. So 50 patients went through whole leg radiographs, as that's the gold standard to assess alignment for genu varum and valgus. And then after that, these different providers were given a picture of the patient, and based on that picture, they were to label them as severe valgus, moderate valgus, neutral, moderate varus, or severe varus. And the conclusion showed that visual inspection is unreliable. Incorrect judgments from clinicians were made between 45 and 70% of the time. Women were at higher rates of incorrect diagnosis, and BMI, surprisingly to me actually, BMI did not increase odds of an erroneous assessment. You might hear in the clinic oftentimes observation becomes more difficult if there's a lot of adipose tissue, and this study found that there was no increased risk of erroneous assessments based on BMI. So you can see here, over 50% of the time, we're unable to identify the difference between severe, moderate valgus and severe and moderate varus. This next study we're going to look at is addressing whether or not those biomechanics and biomechanical changes are associated with patients who have PFP, specifically sitting pain with PFP. That's a very common complaint for patients who have PFP, so this study specifically looked at that. They had 133 participants split into 3 groups. Sitting pain after exercise, and no difficulty sitting. So when they came in for the study, they identified whether they had sitting pain, whether they had sitting pain after exercise, or if they had no difficulty with sitting. Once they got in the study, MRI was used to identify alignment and bony morphology of the knee joint and patellofemoral joint. And what they concluded from the findings is that there's no significant associations between the presence of sitting pain and alignment, morphology, or structural changes. There was limitation to the study. Obviously, they're just looking at sitting pain and not people with PFP in general. However, I think we can probably generalize some of these results to patients who have PFP. And we should understand that knee alignment, morphology, and structural changes are not associated with patients who have PFP. So we're unable to statically assess or observe these varus and valgus changes, and we also understand that these changes within the knee joint itself or static alignment changes are not associated with sitting pain for those who have PFP. But what about dynamic knee movement control? Specifically looking at dynamic knee varus and valgus. This systematic review and meta-analysis included 48 studies. 25 of those studies were specific to PFP, 15 OA, and 8 ACL. The results from the systematic review and meta-analysis actually showed there was moderate evidence that changes to knee and hip frontal plane movements were associated with PFP. So in the patients who had difficulty controlling their knee position in the frontal plane had increased risk for PFP. What was interesting is they did not find an association with transverse plane movement, so the rotational component of that varus and valgus was not associated with PFP. I know we're not talking about this right now, but I thought another interesting finding here was that evidence is limited and uncertain in regards to OA and ACL pain and injuries. So our ability to control our knee, varus, and valgus, there's limited and uncertain evidence in regards to OA and ACL injuries. Conclusion from this study showed that changes in movement control is associated with pain and function in those with patellofemoral pain. So in the clinic, when we observe our functional assessments, when we observe them squatting, stepping up, stepping down, it is important for us to see whether they have the ability to control their knee position and see if they fall into a habit of going into dynamic knee valgus or dynamic knee varus. If they do, then our management strategies may change a little bit. Now that we have a good understanding of the role of the biomechanics in patellofemoral pain, I think it's important that we go beyond that scope and get a better understanding of what a current pain model for PFP looks like. The main takeaway is that the pathophysiology of PFP is complex in most cases. Biomechanics may be associated in some, However, we cannot reduce the patient's pain experience to faulty movement patterns or abnormal changes within the knee joint that you might find on an MRI. Instead, patellofemoral pain is often a nonspecific diagnosis. Acute PFP is typically a result of excessive loading. Chronic PFP is typically associated with various contextual factors. Like you'll see across the body, acute presentations may be associated with that loading difference or that loading problem that they've developed. Chronic diagnoses typically have many more factors playing a role that can be more challenging to address later on. The other thing to keep in mind is that when we're studying these patients, oftentimes experimental pain is different than what a clinical pain looks like. You can see in the top right picture here, during a lot of studies, a nociceptive stimulus is applied, whereas when patients come and present to us in the clinic, if it's not an acute presentation following an injury, it's typically a non-specific pain that there's no nociceptive stimulus being applied. So I think that's an important takeaway as well. If you want to learn more about a current pain model, just in general, looking at pain neuroscience, I would encourage you to read through these bottom two articles. However, don't be surprised if you can only understand about half the words. Pain neuroscience, there's just a ton of really big and confusing words. So they are a bit challenging to read through. I only understood about half of the words. But if you want to give it a shot, go for it. Patellofemoral pain is a common medical diagnosis that you'll see. It typically affects between 7 to 35% of the population, and it has a high recurrence rate at 70 to 90%. In fact, 1/3 of patients who are diagnosed with PFP still have symptoms after 1 year, and 50% of patients have unfavorable outcomes 5 to 8 years down the road. It's even been found that about 1/4 of people have persistent symptoms 20 years after initial diagnosis. And I think the primary reason for that is because we've been so focused on providing temporary pain relief as a fix. I use air quotes there, as we thought that we were fixing this PFP by providing them with temporary relief. And it's really been a mismanagement on our part in developing these long-term chronic symptoms. Instead, if we were to address the patient's pain presentation appropriately initially by using a biopsychosocial and a value-based care model, I think that would help reduce some of these persistent symptoms. It is a common diagnosis across the lifespan with a couple different peak age ranges. Hutchison in 2019 found that 21% of collegiate basketball players were suffering from PFP. It is a little more common in females, and then the peak age ranges are between 12 to 19 when athletics are really common, and then the highest prevalence is between 50 to 59 years old. As always, when it comes to diagnosing something, it's important that we have in the back of our mind there's 4 main categories for diagnoses: red flags, region-specific disorders, region-non-specific disorders, and persistent pain. By far the most common that we're going to be seeing are the region-non-specific disorders. So the most common diagnosis associated with that would be a non-specific diagnosis. If we do have the ability to come up with a specific diagnosis because it's a region-specific disorder, such as an ACL tear or a meniscus tear, or with patellofemoral pain, if they've done a rapid amount of increased movement and they have this loading issue, I think we can come up with a pretty specific diagnosis there. It's more of a non-specific diagnosis. So PFP can be caused by several different things: compressive issues, instability, biomechanical dysfunction. All of these could potentially be playing a role in this diagnosis, and that's why it's hard to come up with any specific term associated with it. And I think later on you'll see the differential diagnosis that in the past we've tried to identify specific structures and label that as the problem or label that as the diagnosis, when instead we found that with somatic referred pain, it's more of just a general non-specific term. Some other factors that may be playing a role in a diagnosis of patellofemoral pain would be growth disturbances. These 2 specific examples of diagnoses are associated with those growth disturbances. You've probably heard of Osgood-Schlatters. I'm sure many of you have had Osgood-Schlatters before. Sinding-Larsen-Johansson syndrome is another one that is associated with growth disturbances. Patellar trauma, this would be the red flag diagnosis, so it doesn't fall under the region non-specific disorder. Soft tissue irritation, Oftentimes associated with overuse syndromes would be considered that region non-specific disorder, and then complex regional pain syndrome is something completely different. However, it can present in the knee, so it's something that we need to have on our differential diagnosis list. A hallmark symptom of patellofemoral pain is anterior knee pain with loading. It could be unilateral or bilateral loading. Location of symptoms, I find that it's generally more vague around the anterior retropatellar position. However, it can be localized to a small area in the knee. Prior history of patellofemoral pain should increase the likelihood of us having it on our hypothesis list. As you're aware, it has a high recurrence rate. This chart on the right labels some different diagnoses and some different structures based on the position or location of pain. Now, I really don't think that we can isolate these structures as being the cause for somebody's pain. However, I do think using palpation in these different areas can be helpful for us and trying to be as specific as possible, in addition to having an understanding of where the patient's symptoms are located. So I would encourage you not to get in a habit of blaming any one of these structures unless there's a traumatic event that really did disrupt those structures. Classic risk factors that a lot of clinicians will describe, or what's taught at a lot of different PT programs, would be physically active females, participation in a single sport, isometric knee extensor weakness, decreased lower extremity strength, knee extension, hip abduction, hip external rotation, and decreased flexibility. Now, most of these have not really been backed up by research as risk factors. Instead, they've been associations. So it is more common for females to have PFP. It is more common for people who participate in a single sport to have PFP. It is more common for people to demonstrate some of these weaknesses if they have PFP. But there's a difference between risk factors and associations. So we're going to look at whether these are causal relationships or if they're associations. And the reason that's important is because if a patient's coming into us and they have this hip extension weakness, but it's not really a risk factor, then we shouldn't be telling them that their knee pain is because of their weak hip. And too often that currently happens. A patient's pain gets blamed on a weak hip abduction, when instead there's a lot of different contributing factors that are actually the cause of the patient's symptoms. You may see the hip weakness with PFP. However, we need to determine based on evidence whether those are really risk factors or not, and that's what's going to happen here in the next couple slides. The first systematic review that was looking at risk factors for the development of PFP included 7 articles, and of those 7 articles, they looked at 135 possible variables that were pooled into 13 potential risk factors. So they looked at everything from the position of your foot, to the weakness in your hip, to the quadriceps and hamstrings weakness, to age, different demographics. There are 135 different variables they looked at, and they grouped them into 13 potential risk factors. Out of all of those possible variables, they were only able to determine one predictive variable, and that was weak knee extension strength. So according to this systematic review, we aren't able to say that your knee pain is due to your hip weakness. It's not a risk factor. It may be associated, but it's not a risk factor. The only one they were able to find out of 135 possible variables was weak knee extension strength. There were several other risk factors for PFP that were described, but those were only found in single studies. So rather than them being determined to be predictive variables, what they said is that we need to do more studies to determine if it's consistent findings. Having one study that shows that a flat foot is the cause of your knee pain is not enough for us to get definitive data. The next systematic review also had a meta-analysis, and it looked at risk factors for patellofemoral pain. It included 18 studies, nearly 5,000 participants, and 483 of those 5,000 participants developed PFP. Okay. Of those 483 people, they were only able to find 2 predictive variables. They assessed a lot of variables. You can see the long list there of what they assessed, but out of all of those, they were only able to find 2 predictive variables for those who developed PFP. The two predictive variables were lower isometric quad strength in military members and higher in isometric hip strength in adolescents. Okay, so here they found the same thing as the previous study did, where decreased quad strength is associated or predictive of PFP. It's a risk factor for it. They also found here in this study that increased hip strength was a risk factor for the development of PFP. So it's the complete opposite of what we've been telling patients for many years. And I think we need to use this evidence rather than focusing on what's been used for years. It's not backed up by anything according to these large studies, including a lot of different patient populations. So the only two that we found so far for risk factors would be quad strength weakness and isometric hip strength being increased. So if a patient comes into you, they have PFP, and you notice that they have weak quads, we can tell them that risk factor for developing this is quad weakness, which you presented with. So that's going to be one of our focal points as we go throughout our management plan. I like this chart from that article looking at the different risk factors for the development of PFP. The reason I like it is because it does a good job revealing that there's a difference between association and causation. Again, in the study, they found that only greater hip strength in adolescent females and lower quad strength in military members were risk factors for the development of PFP. Now, the other two green circles had one study to back them up as far as risk factors for PFP, but again, they said that that's not enough evidence for us to say conclusively whether or not they're risk factors for the development of PFP. So no more research needs to be done. The other thing that you see here is that there is a correlation with lower hip strength and PFP, or dynamic knee valgus and PFP. So you can see how the arrow goes from PFP to lower hip strength. You can see how PFP has an arrow going to psychological factors or psychosocial factors. So when somebody develops PFP, there is a higher likelihood that these other things will come from that as well. More and more research is coming out looking at psychological factors in patients with PFP. Persons with PFP may have higher levels of catastrophizing depression and kinesiophobia. Typically, the patients who do have those signs have higher baseline pain severity, longer duration of symptoms, and poorer function. The screening tools that we can consider using would be the Tampa scale of kinesiophobia, pain catastrophizing scale, maybe even the FAB-Q. Again, my preference is to use the OSPRO initially, and then based on what they respond to the OSPRO, it'll identify whether we should use the PCS to get further information or use the TSK-12 to get further information. So my preference, I should say, is to use the OSPRO to identify whether there's any risks for these psychological factors. Mitchell-Selhorst has also published some good articles looking at adolescents and their psychological factors for PFP that we'll look at a little bit later. Prognosis for PFP right now is poor. There's a high recurrence rate and patients have persistent symptoms even up to 20 years. So I'd say that's pretty poor prognosis for a lot of patients. Then it's important that we identify the different contextual factors that drive prognosis early on so we can focus on addressing those initially in our treatment and hopefully reduce the likelihood of these long-term conditions. 94% recurrence rate has been found, and multiple studies indicates that reoccurrence rates are high. Symptoms can persist 20 years. I mentioned about a quarter of patients who have PFP have persistent symptoms even up to 20 years. You've seen this reference a couple times now. The Wiley JOSPT 2019 article is a CPG that was developed for PFP. So it's a really good reference for you. I'd encourage you to click on it and download it so you can save it as a reference for your future. I mentioned the different contextual factors that we need to assess and address for our patients who have PFP, because those contextual factors may be the ones driving the patient's pain presentation and their prognosis. There have been a couple studies looking at this specifically. However, there's still limited evidence. Nearly every factor you can think of is on the list for trying to determine what the prognostic factors are, because there is such a poor outcome. And unfortunately, just haven't come up with any consistent findings. There is strong evidence available to us that shows that pain coping skills and kinesiophobia is actually not predictive of the development of PFP. However, again, that's different than the prognostic factors. It's not predictive in the development of PFP. It's not a risk factor, but once patients have PFP, it may be associated with the long-term outcome. And this study in 2018 showed that women with PFP had significantly worse kinesiophobia, pain catastrophism, and poor objective functioning. So there's that association linked to it. We also know individuals with longer duration of symptoms, higher baseline pain severity, and poorer function were more likely to have an unfavorable recovery. So it's important that we get ahead of these things as soon as possible so we can address them early on and hopefully reduce the likelihood of them developing this persistent pain presentation. Please let us know if you have any questions.